Good evening and welcome to tonight's webinar focused on lung cancer and what's important to know about testing and treatment. My name is Deborah Carnes and I serve as the Marketing and Communications Director for PeaceHealth Southwest as well as PeaceHealth St. John and Longview. And we really thank you for joining us tonight. Our goal is to ensure that tonight's session is educational and informative and that you're able to get your questions answered by our physician panel. For tonight's format, we do have 5 physicians presenting, and I'll introduce them in a moment. Each one of them brings specialized medical care and services to the detection and treatment of lung cancer, and they will share information with you related to their areas of practice that we hope to be informative and very helpful. A couple of times along the way, we're going to pause for poll questions to gather some additional input, and we encourage you to join in if you'd like by voting, and we'll also allow time for questions at the end. So please be thinking if you have questions, and at any time you can drop them into the questions tab, and we'll get to those along the way. And then finally, at the very end, we have a short survey that will just ask you a few questions to gather some additional input that helps us form presentations in the future, but also allows us, if there are questions that we need to follow up on, we can do that with you too. So with that said, I'd like to introduce our physician panel, who you can see on the screen. Our first speaker and moderator for the evening is Dr. Bhanu Patibandla, and we also have Dr. Gurleen Dhami and Dr. Shushan Rana, and our Dr. Ali Dadla, and then also Dr. Svetlana Kotova. So now I'm going to turn it over to Dr. Patibandla to get us started tonight.
Fantastic. Thank you, Deborah. My name is Bhanu Patibandla. I'm a pulmonologist at Southwest Medical Center in Vancouver. I'm very passionate about diagnosing lung cancer early, and my goal is to provide the comprehensive, best possible multidisciplinary care to the lung cancer patients in our community. I'm very grateful to have colleagues who shared the same passion and vision, and you'll get to meet some of them today. Our goal today is to provide you with all the information, the most important information possible in the management of lung cancer care, so that you know what to expect from and ask your healthcare team just in case you or someone you know is diagnosed to have lung cancer. So we have come up with some topics which we think are most relevant to achieve that goal. So first, you'd hear from multiple specialties, brief presentations, about 10 minutes, and then we'll do Q&A. So I want to tell you all, this is all about you, the audience. So I would encourage you all to please ask any questions you may have about the lung cancer, and we will do our best to get to them as much as possible at the end of the presentation. So I want this to be as engaging as possible, so please don't hesitate to ask any questions. Without any further ado, I would go ahead and start the presentation. These are the topics that I would be covering today. Lung cancer is the leading cause of cancer-related deaths in the United States. 1 in 4 cancer deaths in the United States are secondary to lung cancer. To give you all a sense about the magnitude of this problem, lung cancer kills more people every year than breast, prostate, colon, kidney, and melanoma cancers combined. Lung cancer is also one of the most common cancers. In fact, it is the second most common cancer in both men and women. As it is well known, cigarette smoking is the leading risk factor for lung cancer. About 80% of lung cancers are secondary to cigarette smoking. I want to emphasize here one point. About 20% of lung cancers are identified in patients who are never smokers. I'm highlighting this point because oftentimes lung cancer is misconceived as just a smoker's disease. There are multiple other reasons in addition to cigarette smoking that can cause lung cancer. So one of the main things secondary to cigarette smoking is exposure to radon gas. Radon gas is a naturally occurring radioactive ion gas that's released from the soil containing granite rock. We cannot see it, we cannot smell it, we cannot taste it, and there are no signs or symptoms from radon gas exposure. The only way to mitigate the risk of exposure to radon gas is to check our homes if there are any high radon levels. And this can be done very simply. There are multiple commercially available kit equipments that we can use, or you can ask, you can get a professional service to do that. And in case if your home is found to have high radon levels, there are simple measures that we can take to reduce the levels and thereby the exposure. And if you need any additional information, I would encourage you all to check out this website here. Other risk factors for lung cancer include exposure to asbestos and certain chemicals or metals. And family history is also known to play a role in lung cancer. And if you have any other lung conditions or you have received radiation to the chest, you're also at higher risk for having lung cancer.
Now we're going to ask you to take a quick poll here. I'm going to put it in the window, and if you could just, if you would like to participate, if you wouldn't mind voting, just to give us a little more information about risk factors that are most concerning to you. And we'll just give you a minute to participate, and then we'll share the responses. Okay, let's go ahead and share the responses then. And as you see, looks like other lung disease actually came up higher. So I'll turn it back to you, Dr. Patibandla, and maybe you would want to address that.
Yeah, for sure. That's a good mix of responses. And so certain lung conditions, for example, COPD or pulmonary fibrosis, increases the risk of lung cancer. And for example, in patients with pulmonary fibrosis, the risk of having lung cancer is almost 8-fold. And the pathophysiology or the biology is thought to be, when you have this lung conditions, there is a lot of inflammation in the lungs, and that can cause some genetic mutations and increase the risk of lung cancer. And also, most of those lung conditions are secondary to smoking. So people who smoke are higher risk of having this lung conditions. So that kind of also translates to having higher risk for developing lung cancer. I think one of the things that was noticed on that poll is the asbestos. And one point that I would like to mention about that is asbestos exposure is exclusively associated with a type of lung cancer called mesothelioma. This is a cancer of the lining surrounding the lung. It used to be a problem 20, 30 years ago, but it has now become less and less common because of the asbestos usage being low now in the construction industry. Fantastic. Thank you all for chiming in on those questions. I'm trying to advance the slide. Some technical glitches. Michelle, can you help me with the slides? I'm not able to advance it. Okay, there we go. Fantastic. So it's easy to think that lung cancer is just one disease, but there are many different types. Non-small cell lung cancer and small cell lung cancer are two major types. And within non-small cell lung cancer, again, there are 3 different types of lung cancer. All this is based upon the type of lung cell from where the cancer originated. Today, we're going to talk mostly on non-small cell lung cancer, as it is the most common type. It is important to know the stage of lung cancer when it is diagnosed, because staging determines the treatment, and you would hear more about it from my colleagues in a short while. Also, staging influences the outcomes, including the survival. So I would like to give you all a brief overview on how the lung cancer is staged. There are 4 stages in lung cancer, stage 1 to stage 4. The higher the stage, the advanced the cancer is, or farther it has spread. So For example, if your lung cancer has spread to any other body part other than the lung, it is considered to be stage 4, or commonly called metastatic cancer. Or if your lung cancer has involved the lymph nodes in your chest, the first place where usually the lung cancer spreads to, it is considered as stage 2 or stage 3, depending upon where the lymph nodes are located. So your doctor may recommend to get additional testing, for example, PET scan, MRI of the brain, or sometimes bronchoscopy to understand the stage of your lung cancer before designing a treatment plan. One of the main reasons why lung cancer is associated with such a high mortality is because it is often diagnosed at advanced stages. Lung cancer doesn't cause any symptoms, especially in its early stages. There is nothing like a lump or a bump or any specific sign that raises red flag to suspect lung cancer. By the time lung cancer is causing symptoms, it's often at advanced stages. So one of the best ways to improve the lung cancer outcomes is to detect the lung cancer early. And that can be achieved by doing lung cancer screening. Lung cancer screening is done using low-dose CAT scans. Lung cancer screening recommendations came into existence around 2013 when a large national study showed that screening using low-dose CT scans reduced the risk of lung cancer by almost 20%. Lung cancer screening is recommended for certain high-risk individuals based on age and smoking history. It is recommended for those who have smoked for at least 30 pack years, who are currently smoking, or former smokers quit in the last 15 years, between the ages of 55 and 80. Lung cancer screening is recommended to be done annually, and it is completely covered by Medicare and almost all the private insurance carriers. On your screening CTs or on the chest scans that you get for any other reason, there is a chance that you may be told that you may have a nodule or a mass. So I want to switch gears here and talk about what they may represent. So a lung nodule is a spot in the lung, and it is less than 3 centimeters. It is something solid. And if you think about it, the lungs are filled with air, and the lungs are just like a sponge. There shouldn't be anything solid within the lungs. So if you find the spots within the lung, we need to be able to explain what they represent or why they are there. The most important reason why we care about the lung nodules is because some of these nodules could be cancer or could become cancer. But the good news is not all the lung nodules. In fact, majority of the lung nodules are not cancer. There is a long list of conditions that could cause lung nodules. But if you think about it from the patient perspective, only 2 things matter. Is it cancer or is it not cancer? So we use multiple tools and risk prediction models to help answer that question. And here is some of the most important information that we gather when we meet the patients and when we review the CT scans. Some of these characteristics are associated with a higher risk of malignancy. For example, if you have a patient who is a heavy smoker or who is older or have a previous history of cancer, that puts them at higher risk of having a lung cancer. And we plug in all this information into the risk calculator tools we have and come up with the probability of the lung nodule to be malignancy. To put it simply, one way to look at it is that the larger the nodule, the higher the risk of that being malignancy. And also the nodule appearance would have an influence of that being a cancer. For example, if the borders of the nodule is irregular and having the spiky appearance as it is shown on this slide here, the risk of that being a cancer increases. So once we determine the probability of the nodule to be a cancer, usually one of the 3 following approaches will be recommended. If the probability of malignancy is thought to be low, you would be recommended to get a follow-up CT scan in 3, 6, or 12 months, depending upon the risk of the nodule to be a cancer. Sometimes, if the probability of the nodule to be cancer is high, going straight to the surgery for resection may be appropriate. But if the probability of the malignancy falls in between, you would be recommended to get a PET scan and sometimes get a biopsy. I would like to talk about the biopsy modalities here because there are multiple options to choose from, and each has its own unique advantages and the risks associated with it. So I would focus on that in the next few slides. So there are three ways to get lung tissue or biopsy the lung tissue. One option is to do a small surgery and remove that portion of the lung. Another option is by sticking in a needle through your chest into your lung tissue and take a biopsy. This is done using CT guidance, and this is done by the intervention radiology team. And third option is done by pulmonologists, and this is done using bronchoscopy. This approach is safest of all the biopsy modalities and gives us a lot of information. And I would like to talk more about the evolution of the bronchoscopy in the last 10 years because that's been an exciting advancement in the pulmonary field in general, and in particular with the lung cancer care. Historically, we have had some limitations with doing lung biopsies using the conventional bronchoscopy, mainly because we were not able to go deeper into the lung. And so most of the lung nodules are found in the periphery of the lung. So with the conventional bronchoscopy, we're not able to reach those areas. So we came up with a navigation technology just similar to what we have in the cars. We take CT scans of the patients, we create a 3D airway map in the lungs, and we use the navigation guidance to go far and deeper into the lung. This has been a significant advancement in the peripheral lung biopsy. Our success rates with lung biopsy has improved, but we still continue to have some technical limitations with getting the right tissue all the time. If you think about it, the average surface area of the lung is about the size of a tennis court. And we are going after the spots in your lung as small as a pea, about a centimeter. So we are trying to find a pea in a tennis court. And you can understand the challenges with it. And on top of it, the lung moves up and down as we breathe. So it's like biopsying a moving target. So we've been looking for a system which is more stable and able to give us an opportunity to precisely and safely biopsy the lung tissue. And that's where the robotic assistance plays a role. It gives me immense pleasure to be able to offer this cutting edge technology to the patients in our community. And we've been using it for the last 5 months and are able to provide great results for our patients. And now we're able to go deeper into the lung. We're able to perform lung biopsies much more safely and precisely and very reliably using the robotic assistance. Here I'm showing a picture of a CT scan from one of my patients wherein we are seeing a nodule in the right middle lobe. And in the bottom panel, you're seeing a scope that's advanced all the way deep into the lower portions of the lung. And this level of reach and this level of precision is something that wasn't possible before. And this patient was offered the diagnosis and staging and everything all at the same time. I wanted to show you all a video about how the procedure goes, but we will not be able to play it here, but I think you would be able to access it in the files that you will be getting after the talk. So I would encourage you all to kind of take a look, and it will give you a good idea about what the procedure entails. When we do lung biopsies using bronchoscopy approach, it's not about just biopsying the lung tissue. We do a lot of things at the same time. Let's say we sample a lung nodule and it turns out to be cancer. Then we can, at the same time, in the same procedure, look at the lymph nodes in your chest, because that's the area where the lung cancer usually spreads to. And that is important to understand the stage of your lung cancer. So we will be able to do it at the same time. And also sometimes when we think that the patient may choose or benefit from receiving radiation after the procedure is done, we place fiducial markers, as you're seeing here on the chest X-ray. And Dr. Dhami and Dr. Rana, when they meet the patients, they can go forward with the radiation treatment. And now we are planning to combine the biopsy and surgery to be done on the same day in the same OR. So we're trying to combine multiple steps or multiple interventions into one singular procedure, so that we provide the patients as much information as possible without needing to do multiple procedures, and help them move to the next steps as efficiently and as safely as possible. So this is really an exciting time in lung cancer, and we are super excited to be able to provide all the services to the patients in our community. With that said, I would conclude the portion of my talk, and these are the topics that we have touched upon today so far. And one thing that I would ask you all to take away from whatever I've said so far is lung cancer screening. You know, if you smoke or have smoked in the past, or if you know someone who has smoked and is more than 55 years old, please talk to your healthcare team if you would qualify for lung cancer screening. It definitely saves lives. And one thing also I would like to emphasize here is that if you're told that you have a lung nodule, please don't stress out. As I said, there are multiple reasons why you may have lung nodules. I would encourage you to see or find someone who may help you with that. I would take any questions if you may have. Please feel free to drop them in the chat box. And I think Deborah is going to take one more poll question here. As you can see here, we're interested to know what motivates you to quit smoking, if you have already done so, or if you're planning to quit.
So here is the poll up on the screen, if you wouldn't mind participating. And then once we get through this, Dr. Patibandla, there are a few questions in the chat that maybe we could go over before we move on to the next presenter.
Yeah, totally.
We'll give you a few minutes to vote on this, or a few seconds, I should say, and then we'll close it up. Okay, it looks like the results have a decreased risk of getting cancer being the top motivator here. So Dr. Patibandla, a few questions that came in while you spoke. What is the risk from low to high for each biopsy modality?
Okay. Yeah. So let me. Yeah. So there are like 3 biopsy options we talked about. One is a surgical biopsy. That's definitely, you know, much more invasive than the other biopsy modalities. Dr. Kotova in her talk will show you all the advancement that has happened in the thoracic surgery in terms of decreasing the size of the incision that's needed to do the lung surgeries. But it is still a surgery. You know, they're cutting you open and they're taking out a portion of your lung. And if it turns out to be not cancer, you're losing a portion of your lung for a benign condition. So that's the risk associated with the surgical biopsy. It's much more invasive, and there is a chance that it may not be a cancer, and you may lose a portion of your lung for a benign condition. And for the second procedure that I showed you all, which is the CT-guided biopsy, the major complication with that is something called pneumothorax. What it basically means is that if you think of lung as a balloon, it has a lining around it. And the lungs are physiologically not supposed to be poked from outside. When you're kind of putting a needle from the chest into the lung tissue, there is a chance that you may cause the lung to collapse. And the risk of that happening with the needle biopsy is about 30%. So 3 in 10 patients who go through this procedure may have this complication, which may sometimes require putting in a chest tube. Sometimes they may need to be hospitalized. And some of the complications is having bleeding in the lungs, but it's not really a major complication as it is the case with the pneumothorax. And if you compare that to the bronchoscopy approach, the risk is still there for the pneumothorax, but it is substantially low. And compared to 30% with the needle biopsy, the risk is less than 5%. And as the technology is advancing more and more, it's actually, less than 3%, meaning 3 in 100 patients may have this complication. So I would say those are the risks and benefits with these procedures. And also, as I was emphasizing, with the bronchoscopy approach, you would have much more scope for getting much more information. Any more questions?
We have some more questions, but let's go ahead and move on because some of them, I believe, might be answered from the other presenters. So if we could go on to the next presenter, please.
That's a good idea. Feel free to keep submitting your questions, guys. We would definitely like to go over them as much as we can. And it is my absolute pleasure to introduce you all to Dr. Dhami and Dr. Rana. They are our radiation oncologists and are an exceptional team. I always lean on them whenever I have a case. So it's an absolute pleasure to have them talk about this topic today.
Thank you for having us. We are honored to speak today. November is actually Lung Cancer Awareness Month. Our goal is to raise awareness and amplify the conversation about the importance of early detection and treatment. My portion of the radiation discussion is broken down into 3 categories. First, I will provide an overview of radiation therapy. Secondly, I will review the radiation oncology workflow. Lastly, I will discuss the treatment machines used in radiation therapy. Thereafter, I will hand over the discussion to Dr. Rana, who will review more in detail about the treatment delivery and the side effects. Radiation has been commonly used in patients with lung cancer, ranging from palliative intent to help alleviate symptoms from the cancer, or of definitive intent where we're actually trying to go for a potential cure. For early stage lung cancer, a short course of pinpointed radiation therapy to a high dose is recommended, ranging from 1 to 5 sessions of treatment. You're done within 2 weeks. This is called stereotactic body radiotherapy. Another approach is to deliver the radiation over 6 to 15 treatments, which is called moderately fractionated radiation therapy. This is in contrast to more locally advanced lung cancers, where radiation therapy is delivered over 6 weeks daily, Monday through Friday, and is often administered with chemotherapy. I like to take this time to review radiation therapy. I often use a flashlight analogy with my patients. Imagine you have a flashlight in your hand and it's directed to the wall in a dark room. The middle of the light is very bright. As you go further and further out from the center, the light becomes dimmer until the outer edge is black, where there is no light. This is very similar to a beam of radiation, and the dose of radiation representing the different intensity of brightness you see on the wall. Now, grab 2 of your friends. Each of the 3 of you have a flashlight directed into the same point in the room, which is in the center. The brightest part of the light is where there is complete intersection of all 3 flashlight beams. As you get further and further out, the light dims down. The work is divided by 3 flashlights, which means each of the flashlight has to do a good amount of work to get the center of the room bright in intensity. Now, imagine you have recruited your friends and family for this flashlight beam, still centered in the same spot in the room. Similar to before, the brightest part of the light is where all flashlight beams intersect, which is in the center. As you get further and further out, the intensity is less. In contrast to using 3 flashlights, when you use several flashlights, the brightest part of the inner circle constricts, which means it gets smaller. With radiation therapy, we use multiple radiation beams at different angles to target the same point, which is the tumor. To the highest dose, consider the brightness of that yellow color, and it conforms around the shape of the tumor. As you go further out from the center, the dose is much less, which is represented by dimming of the light, which is the lighter yellow color. Additionally, in contrast to the 3 flashlights, when we use several flashlights, it means each flashlight is workload is significantly less to be able to brighten up the target in the center. This is why we use several radiation beam angles to target a tumor in order to get a higher dose to the tumor in the center and less dose to the organs around it. For early stage non-small cell lung cancer, radiation therapy is now the standard of care treatment for patients who are not physically fit or refuse radical surgery. The first question you may ask is, what is SBRT? Well, SBRT is called Stereotactic body radiotherapy, which delivers a high dose per treatment session over a small number of treatment sessions, typically 5 or less, in a very precise manner to the tumor with a very rapid dose fall off in the surrounding lung tissue and adjacent tissue. Going back to the flashlight analogy, think of the brightest part of the beam as a small inner circle and the remainder of the small circle as a dimmer shade. The overall size of that circle, of that flashlight beam, is very small. The image on the left of the slide shows how multiple different radiation beams are used to target a high dose of radiation therapy to a pinpoint tumor. Now point your attention to the right image. This shows the tumor in the lung, which is in white. And you can tell that the radiation dose we want to give to the tumor is actually depicted in red, with a rapid dose fall off as you get further away from the tumor. This dramatically reduces the dose to the critical real estate nearby, such as the heart, remainder of the lung, spinal cord, airway, and vessels. Now we will shift our discussion on the treatment for locally advanced lung cancer, which involves a larger primary tumor or involvement of regional lymph nodes. Conventional radiation is when radiation is delivered daily, Monday through Friday, over several weeks. Traditionally, classic radiation fields use bony landmarks and X-rays to target tumors. This is really archaic now. We then transitioned to 3D conformal radiation, where we used a CT scan and we pre-designed radiation beams in 2 to 4 directions to target the tumor. This still was not ideal because the fields were still quite large and included critical structures in the high dose region, which increased the potential side effects, and we really were limited by how much total radiation dose we can deliver to the tumor to have the best outcomes. Now, with the advances of modern radiation therapy techniques, such as intensity modulated radiation therapy, called IMRT, we are able to conform precisely to the 3D dimensional shape of the tumor by changing or modulating the radiation beams into multiple smaller beams. This allows us to give a higher dose of radiation to the tumor while sparing healthy tissue around it. Since a target is often near normal structures, the risk of long-term side effects are reduced by giving the radiation over a longer course so that normal tissue has the ability to recover and repair damage from the radiation. Now I want to point your attentions to the images on the right. The left image is 3D conformal radiation using 3 beams to target the tumor. Think of this as a 3-friend flashlight analogy. The highest dose is in red, and the green and yellow, white, and white lines represent lower doses of radiation. We really want that red line, that high dose of radiation, to mimic the shape of the tumor target with less spillage of this red color into the normal tissue. Now compare this to the right image, which is using IMRT with multiple radiation beams to target the tumor. Think of this as a several friends and family flashlight analogy. The red area is constricted, which means a higher dose of radiation conforms better to the shape of the tumor and less outpouching of the red lines into the normal tissue. You can also see the white, green, and yellow lines are constricted as well, meaning that the normal tissue is seeing less radiation. This slide illustrates the steps in the radiation oncology workflow from the time a patient is evaluated in consultation to treatment delivery. Once a decision has been made for a patient to proceed with radiation therapy, the first and an important step is a simulation. Radiation therapy must be aimed precisely at the same target each and every time treatment is given. During a CT simulation, a patient is placed on the simulation machine in the exact position of the actual radiation treatment. The target area is marked and custom pillows are used to ensure reproducible setup. Once a simulation scan is done, the patient goes home and these images of the CAT scan are imported into our treatment planning software. Behind the scenes entails contouring the target volume structures by the radiation oncologist, and thereafter we make an individualized treatment plan which is reviewed. And once that plan is approved, there's a lot of patient-specific quality insurance procedures that have to be performed and must pass before treatment can be initiated. Now I want to talk to my next point, which is what tools do we use to deliver treatment? Depicted on the slide are two machines we use here at PeaceHealth Southwest for delivery of radiation therapy. The picture on the left is a medical linear accelerator, LINAC for short, which generates photons or X-rays used in 3D, IMRT, and SBRT radiation. The machine is the size of a small car. It's approximately 10 feet high and 15 feet long. The vast majority of cases are treated on this machine, including locally advanced lung cancers. The second picture on the right is the Cyberknife system. This is the only system available in the Portland metro area. This is a non-invasive treatment in certain cases where radiation therapy is indicated. It is used to treat many conditions throughout the body and can be performed as an alternative to surgery. Treatments are typically performed in 1 to 5 sessions. A common question that is asked is, how does the Cyberknife system work? The Cyberknife system has a linear accelerator, the LINAC, mounted on a robot to deliver radiation therapy using real-time image guidance, and a robot to deliver a dose from hundreds of beam angles. The robot moves around the patient, allowing multiple angles of radiation therapy to target the tumor while minimizing dose to the healthy tissue and real-time tracking of the tumor. This keeps the radiation on target even when the tumor is moving with breathing. There are multiple advantages for Cyberknife radiotherapy. One is that there's not any invasive procedures that are required for immobilization of that part of the body. It's also a highly ablative dose of delivery with goal to ablate the tumor. We also use frequent imaging of the tumor during the treatment, and the robot makes the fine-tuned adjustments in real time, which means we can add a smaller cushion margin around the tumor so we're treating less tissue. We also are able to reduce the overall treatment time from several weeks to anywhere from 1 day to 1.5 weeks of treatment for patients who are eligible for this. And each treatment takes about 20 to 45 minutes. Now I will hand it over to Dr. Rana, who will discuss more about the treatment delivery and side effects.
Thank you, Nina. Let me get my thing situated here. Sorry, 1 second. So next slide here. Oops, sorry. Thank you, Nina. I'll be talking about the side effects during radiation and what to expect after treatment's all done. There are a few side effects that can occur during the course of treatment, and it largely depends on how big the tumor is or if the cancer is spread to lymph nodes, which are located in the middle of the chest right above the heart. Both factors determine how big the radiation field will be and to what extent the healthy organs adjacent to the tumor receive radiation. So side effects also depend on whether you receive chemotherapy at the same time and how well your general health is before treatment, specifically how well your lungs look on the CT scan before treatment, and whether you receive SBRT or a longer course of radiation. For patients who are treated with SBRT, most patients don't experience any acute side effects during treatment, except maybe a little bit of fatigue, which can linger on a few weeks, and then the energy level gets back to normal. And then for the longer course of radiation, which involves chemotherapy at the same time, patients can experience some irritation of the esophagus, which is called esophagitis, starting around the end of the 2nd week of treatment. And we typically start patients on an antacid if they're not already on one, and make sure there aren't any infections like a thrush reaction, like a fungus. So if that's the case, we give an antifungal medication, which clears it up in a few days. A handful of patients can get slight worsening of a cough, but with modern techniques of radiation, like Dr. Dhami discussed, we see that very rarely. And then skin changes were a side effect associated with radiation for lung cancer, but with modern techniques, we don't see that skin reaction, which is a dermatitis. We may see some skin redness, and if that's the case, we give lotion to counteract that sunburn reaction. Oops, sorry, here we go. So how do we know radiation worked? I think one of the questions is how early does SBRT show effects? We follow you for quite a while after you're done. So first year or two, we follow you every 3 to 6 months, then yearly thereafter. And the questions I ask on each visit is, did we kill the tumor, and is the tumor still dead? And the second question is there any radiation damage that needs closer attention? So at the end of treatment, the cancer cells are dead, but they're in a scaffold. They're in this housing in which the cells lived in before. So the point of that being, in some cases, we do see shrinkage, but there is scar tissue that replaces the dead tumor, and scar tissue related to lung scarring of normal tissue. So essentially, as much as we'd like to see disappearance of a nodule on the CT scan, we see a replacement of scar, and we follow that over time. But we do, with a great amount of certainty, we know that the cancer is dead in that area. So the second question, what about radiation damage? So the longer term side effects depend again on the size of the tumor, but also where the tumor is located. The picture on the left shows a CT scan snapshot of a tumor closer to the chest wall. So just to orient you with CT scans, imagine that the soles of your feet are sticking out of the screen, and then the crown of the head is moving behind the screen towards that back wall. And then we're flipped kind of backwards. We're looking up from the feet towards the top of the head. What you're looking at with the circled dots there are the right side of the chest. The black things along there, the gray structure in the center is the heart, and the back part, you can see the spine and the bottom of the image. So all that to say is that you see colored spots there close to the chest wall. That's where the radiation is going. In terms of side effects, we can have some lingering fatigue in SBRT patients. That's rare. There can be underlying skin thickness because the skin cells can thicken up in a reaction to radiation, and we call that fibrosis. We may have some patients may have some muscle irritation that can cause some chest wall tenderness, and the rib can become slightly weaker. And that's the reason behind that is bones have fewer blood vessels, and the radiation does affect tinier blood vessels of the bone to cause them to have less blood flow, less nutrients, and cause them to be a little bit more brittle, leading to rib fracture. Very rarely do I see that. It's patients who have minor trauma, they slam into a wall or fall, and it just takes a while to heal, longer than people who haven't had radiation, and there's no surgical intervention for it either. For tumors closer to the middle of the chest, as seen in the right-hand image, this view is looking straight at the person. And if you can see that kind of mustache, kind of W black outline, that's where the airways split into both the right and the left lung. In these cases, the side effects are similar to what I mentioned previously, but it's closer to the chest and the airway as well, the chest in the middle and the airway as well. So there may be lung inflammation, which I'll talk to you more about in a second, and rarely do we see lung collapse or atelectasis or bleeding from the airway. In order for us to minimize these side effects, we adapt the dose and change our beam geometry to reduce the probability of these side effects from occurring. So the side effect I usually keep a close eye on, Dr. Dhami, as well, on each visit is the tumor shrinking? Is there a scar? Or is there presence of radiation pneumonitis or inflammation of the lung? Most patients will have some scarring we see on CT scans every 3 to 6 months. But if there's symptoms associated with it, usually in the form of a mild cough, a low-grade fever, or taking a deep breath and not being satisfied, these features, along with the CT scan, which shows haziness in the lung, and the fancy term for that is alveolar ground glass or consolidated opacity. We just say haziness in the lung. And we rule out there's a bacterial infection. We have to take all those in combination, and that gives us the diagnosis of pneumonitis or inflammation of the lung. The treatment for that's pretty straightforward. It's about it's taking steroids for about 4 to 6 weeks. Again, this is a rare side effect that we look at for closely, and if we see it, we jump on treatment right away, and it resolves it in over a course of a month or so. And then lastly, during our follow-up visits, we're pretty keen on looking for other rare side effects, including fibrosis or permanent lung scarring. Rib fracture, as mentioned before, if it does ever happen, it typically happens about 1.5 years after treatment. If the tumor is closer to the esophagus, we look for possible stricture or narrowing. This is rare. It can happen a few years from treatment. And I usually have patients see a gastroenterologist, and they do a procedure called the dilation, which they take a balloon and guide it through an endoscope, like a bronchoscopy procedure, and inflate it to break up the scar tissue. And that opens up things for the patient to eat better. Lastly, radiation to the heart is a concern that was prevalent with older techniques, but with modern techniques, we have less concern for that, and a cardiologist is usually on board to help us with any concerning cases. So with that, I'll transfer it over to our next speaker, Dr. Dadla.
Thanks, Shushan. Hello, everyone. My name is Dr. Darla. I'm one of the hematologist oncologists. We treat blood disorders and cancers. It's very nice to meet everyone through this platform. And I'm very honored to share with you some insights on immunotherapy and share with you some of the latest treatments that we can offer our patients at PeaceHealth. So I'll start with the very basics, and I think it will be a good precursor to the upcoming slides. So what is cancer? And if you look at the upper part of that slide, normal cell division occurs at a slow rate. It occurs at a slow clip, and when the cells get damaged, they're absorbed by the body. But cancer cells, they divide really quickly, and there's uncontrolled growth. And so the next question would be, why is there this uncontrolled growth? Well, there are genetic changes or mutations which occur in the cancer cells, and so the growth gets uncontrolled. Also, the body's immune system finds it hard to recognize these cancer cells, and it finds it hard to, destroy these cancer cells. So there's uncontrolled growth of cells. So what is chemotherapy? Chemotherapy are basically traditional anti-cancer drugs that kill fast-growing cells. And so it kills anything that's fast-growing, and it has been the cornerstone of treatment from the 1950s right up to 2014. That's what most medical oncologists use. And the common chemo side effects actually occur from chemotherapy killing fast-growing cells. So if it kills fast-growing hair cells, there's hair loss. If it kills fast-growing gut cells, there is nausea, there could be diarrhea. If it kills fast-growing bone marrow cells, there could be fatigue. So that's the reason, chemotherapy has received this bad rep because of, its concomitant side effects. And what is immunotherapy? So immunotherapy is very different from chemotherapy. Immunotherapy is basically an immune boosting drug, a drug that unleashes the body's immune system against cancer with very minimal side effects. And this is where we're moving towards. As oncologists, we try to move away from toxic therapy towards treatment that is more easy to tolerate, that uses the body's immune system, that is more targeted to the cancer, and that way we can prevent side effects for our patients. So how does immunotherapy work? Please bear with me on this one. If we look at the first part of this picture, you have this blue color immune cell called T cell, and you can, you have the blue color cell, the T cell, and you can see the tumor cell in yellow out there. And the way the immune system recognizes the tumor cell is that it binds using that antigen, which is in orange. And there is a part of this binding mechanism called PD-L1 or PD-1, which is a checkpoint. So that checkpoint, it prevents the immune system from going into overdrive and just attacking, different cells which help with normal function. The most common kind of immunotherapy that we use in lung cancer are called checkpoint inhibitors, And what these drugs do, as you can see in the second part of that picture, the anti-PD-L1 and the anti-PD-1, is they block that regulatory checkpoint system, so it allows the immune cell to attack the tumor cell and kill it. So immunotherapy side effects are very rare, about 5 to 10%. We see about 10% of the patients having inflammation of the thyroid from the immune system attacking the thyroid and causing some decrease in the thyroid hormone. And all we have to do is replace the thyroid hormone in that situation. So we monitor for that. Less common side effects under 5%. We see some patients have a skin rash. We use steroids to treat that. Some patients could get diarrhea. Some patients could get liver inflammation. But most of these side effects with checkpoint inhibitors are pretty rare. I would say most commonly we see inflammation of the thyroid and mild skin rash, but for most, it's very well tolerated. It's like taking a bag of saline every treatment that you get it. So moving on, what is personalized or precision medicine? So this is the most custom treatment you can get in the world. It's treatment that targets genetic changes in your cancer. So when Dr. Patibandla takes a biopsy, we take that tissue and we send it for special genetic testing to see if there are any targets on the cancer cell which we can specifically target with the drug. And most of these personalized or precision medicine drugs are actually oral drugs. This is as custom as it gets, and with the least side effects. So we are very excited about the future of personalized or precision medicine. This is also called as molecularly targeted medicine because it targets the genetic changes. So when is surgery or radiation by itself sufficient? When can we avoid all of these drugs, the chemotherapy, the immunotherapy, the targeted therapy? Most of the times that we can avoid it is when we catch the cancer early. That's why screening for lung cancer is very important, because when we catch lung cancer early, that is the best time to treat it. You can easily treat it with just surgery or radiation if you're not fit enough for surgery. And the survival rates are the highest when you catch lung cancer early, when it is in stage 1A, the earliest part of stage 1, that is less than 3 centimeters, and you can remove it with clean margins. You can get the best survival. That's why, you know, CT lung screening has a very big advantage. It adds a very big advantage to survival, and we really think that we can save a lot of our, you know, the patients who have lung cancer. We can prevent it from spreading. So it's better to catch it early than find out later when it has advanced to stages when it's difficult to treat. So for lung cancer that goes beyond stage 1A to stage 2 and stage 3, we think of it more as a poppy plant. And I think this would be the best analogy that I can use. So let's say you have a lung cancer that's over 3 centimeters, then it has the potential to spread and invade into other body organs. So when you have a stage 2 lung cancer, we can cut this out, but it's very difficult to say if there's any spread of the seeds, the poppy seeds, and other parts of the body. And in order to kill those small seeds that have spread, the small seeds of cancer, what we call micrometastasis, we use chemotherapy and immunotherapy to wipe it down to prevent the cancer from recurring. So who is eligible for immunotherapy? Most of stage 2 lung cancers are eligible for immunotherapy depending upon a score on the tumor called PD-L1 score. We test that with a special test called PD-L1 test, and if it's over 1%, then we have good results with stage 2 lung cancer. And all of stage 3 and stage 4 lung cancer we can treat with immunotherapy. And who is eligible for personalized medicine? So for personalized medicine or molecularly or genetically targeted medicine, you do need an actionable mutation which you can target with that pill. And these mutations are commonly found in those who have never smoked, not so common in those who have smoked, but very good results with molecularly targeted medicine. So this is an important slide because it has the greatest impact. Average age of lung cancer diagnosis is 70 years, and 86% of patients are smokers. So it's above 80%. So we have an above 80% chance of preventing lung cancer by working on smoking. Now, we should not look at smoking as a vice. We should look at it as a problem. You know, there are people who have smoked due to their, you know, their own circumstances. And at this point, what should we do going on from here? Quitting smoking reduces the risk of lung cancer starting 5 years, you know, from the time that you quit smoking. And most of that risk is reduced at the 10-year time point. And there is almost, your risk goes back to the general population at the 15-year time point. Quitting smoking before the age of 40 decreases that risk by 90%. So that is the greatest impact that you can have on quitting. But I wouldn't be disheartened if you're a 53-year-old and you're listening to this. Even if you quit smoking at this point in time, you decrease your risk of lung cancer by 80%. So we have time. The average age of diagnosis is 70 years. Working on quitting is very important. And I thank you for your time, and I wish you the best of health. And for those who are battling lung cancer, I wish you all the strength to go through this challenging time. Thank you so much. And we can go. Okay. I'll hand over to Dr. Kotova, who's our new surgeon at PeaceHealth.
Thanks. Thank you so much, Dr. Dadla. I think, fantastic. Dr. Kotova is able to join. I will let her take over from here. She was just finishing up the surgery. I'm so excited to see her face, as you may have been too. Fantastic.
Thank you so much. My name is Svetlana Kotova, and I'm a thoracic surgeon at PeaceHealth, and all of us represent all the members of physicians who take care of patients with lung cancer. So just a quick historical slide. Lung cancer, even 150 years ago, lung cancer was super, super rare. And then just over a couple decades after that time, as smoking started picking up, the incidence of lung cancer increased manyfold, increased about tenfold or so. And very shortly after that, the earliest physician who detected the link between smoking and lung cancer was a German physician, Dr. Licken. And then over subsequent decades, it took quite some time until it was confirmed until the US Surgeon General stated that the smoking actually is the cause of lung cancer and laryngeal cancer, and that's already in the 1970s. So now, 100 some years later, we go from one of the most rare types of lung cancer to the second most common cancer among men and women, and also the highest killer of all people among all malignancies. Now, when was surgery used for the first time? The first successful surgery to treat a patient with lung cancer was in 1933 by Dr. Graham. And actually, the first patient who survived that type of surgery was also a physician who was found to have lung cancer. If you think about how surgery was done about 90 years ago, we really didn't have good anesthesia. We didn't have antibiotics. We didn't have intensive care unit. We didn't have ventilators. The surgery had to be done in about an hour just because of the type of anesthesia which was used. That patient stayed in a hospital for 2.5 months, but survived and lived for several decades afterwards. So this is what surgery used to look like. Thoracotomy is the traditional incision. This is what was done 88 years ago for the first successful surgery. At that time, 2.5 months at the hospital. Now it's about 5 to 8 days, even if the traditional approach is used. However, over the last 20 years or so, we've made significant improvement in our surgical technique, and not just in surgical technique, but in a lot of other improvements in terms of pain management and anesthesia, and our overall understanding of physiology has improved. Now we can do the same surgery with much smaller incision. As you can see in the middle, it's just 2 small incisions, and that's thoracoscopy. Patients in the hospital about 2 to 3 days or so. Fast forward another 10 years. So for the past 10 years or so, new technology that has been coming along is the robotic surgery. Now we do this with much more sophisticated instruments, and the outcome is that your overall recovery is not as long, it's expedited. So as you probably already heard this, but this is just to review a little bit stepwise approach to lung cancer. Early detection is the key. As you already heard that with detection, with lung cancer screening and detection, we are able to detect patients who are at a very early stage, so that here we have many more options to achieve cure. Staging is the next step that all patients have to go to, so that based on this, we can identify those who will undergo either surgery or chemotherapy or radiation, and based on your particular factors can devise the specific treatment plan. What's the role of surgeon in lung cancer? If you think about this as only just cutting out the lung, yes, that's part of it, but that's not the only part of it. In patients who have early stage lung cancer, at times we do surgery just to confirm diagnosis, or to confirm that this is early stage, or confirm that there is potentially a higher stage, so that we can determine whether surgery right now or surgery at a later time after radiation or chemotherapy is the most appropriate step. For those patients who have advanced lung cancer, frequently diagnosis, if biopsies have not been conclusive, which were done in a non-surgical method, sometimes we'll have to resort to doing a surgical biopsy, or even obtain additional tissue for more thorough testing, so that based on particular mutations, as you already heard, specific treatment modalities can be used. Now, for patients who have advanced or potentially metastatic lung cancer, so there are some surgical options that can be used as well. And this is, for example, sorry, 1 second. It's a motion sensor for the light. For patients who have advanced disease and those who are potentially developing more significant complications, such as fluid buildup around the lung, we can do procedures to help and control those symptoms, or potentially deal with some things when the tumor is obstructing part of the airway or compressing other structures. So surgery can be used at multiple times during the treatment, at the early time, and also at later stages. Just a couple notes about what type of surgery is done. The most common surgery for lung cancer is called lobectomy, where we take out a unit of the lung where the tumor is sitting. There are 3 parts or 3 lobes on the right side, 2 parts on the left side, and depending on the size of the tumor, lobectomy is the most common operation. However, as you heard from prior speakers, with lung cancer screening and early detection, we can identify tumors which can be much smaller. And if they're located in particular areas, such as you can see on this, on the left side, a much smaller nodule at the very top of the lung, but here doing a lobectomy may not be the best for the patient, because then you're taking out a lot of lung. So the idea is that we're able to spare a significant portion of the lung and modify the surgery to take out a smaller portion. So as we detect smaller tumors during lung cancer screening, we are able to adjust surgery as needed for inappropriate situations. So multidisciplinary lung cancer treatment at PeaceHealth, as you already met, probably the major players and major physicians participating in this. So once the nodule is detected and patients complete the staging, what usually happens next? Here we have ion bronchoscopy, where biopsy can be done, and with the results yielding right away, and then you can proceed with surgery at the same time if that's appropriate, so that here you're potentially saving several weeks of wait time between each procedure, when it's done individually. Or if surgery is not appropriate at the time, then the area gets marked with special clips, and then patient proceeds to radiation very quickly. Or if biopsy confirms that there is more advanced disease, then the next step would be to proceed with with chemotherapy. So just to summarize, we are part of a multidisciplinary specialty. Treating lung cancer, especially in the last 10, 15 years, has changed, and that's what allowed us to make such tremendous progress in achieving much better survival. Is when we think through these patients together and we collaborate heavily. You don't have to figure it out all on your own. We are here to help you and guide you through this treatment path. And here, I'm going to turn it back to Dr. Patibandla.
Fantastic, Dr. Kotova. Thank you so much for joining after such a long day. I'm very excited to see you, and that's a fantastic presentation overall. And I think we are just past time, but I think we would stick around for a few more minutes and take some questions. We've had some interesting questions sent over already, and most of the questions are kind of revolving around screening. So I would touch upon it, and I would ask you all to kind of chime in if you need to add in more information. I think one thing that's kind of evident after listening to all of us today is that detecting the lung cancer early is one of the best ways to improve the lung cancer outcomes. And one of the best ways to detect the lung cancer early is to get the lung cancer screening. And some of the questions that were asked is like, who qualifies for lung cancer screening? It is not for everybody. It is only for high-risk individuals based upon the smoking history and the age. And it's based upon, if you have smoked for at least 30 pack years, meaning the pack years are calculated based upon how many packs you smoke in a day, multiplied by how many years. For example, if you smoke 1 pack per day for 30 years, that counts as 30 pack years, or 2 packs per day for 15 years, that also counts as 30 pack years. And if you're between the ages 55 and 80, you qualify or you meet the criteria for lung cancer screening. And another question is, who does the screening and where to go for the screening? I would encourage, if you are a current or a former smoker meeting the criteria that we just touched upon, to discuss with your primary care provider or your pulmonologist or anyone in your healthcare team about getting the screening. To get the low-dose CT scan, there is a need for the physician order. And once that discussion is done, and once the low-dose CT scan is ordered, it can be done pretty much everywhere. And we have radiology services pretty much everywhere at this point in time throughout the country, except in some rural areas where we are still seeing some difficulties with getting the screening intervention, but they're available pretty much everywhere. So you can find a radiology facility, and you may get help from your healthcare team to find one, and you can get the screening study there. Anybody want to add anything on the screening?
I think there was a question about the dose of radiation on a low-dose CT scan. It's about 1/5 the dose of a regular CAT scan, so it's significantly low dose. That's why it's considered a low-dose CT of the low-dose lung cancer screening. So significant low dose. Fantastic.
Thank you, Dr. Dhami. I think on the same note, there is one other question asking about the risk itself with the low-dose CT scan. There certainly is risk with any radiation, and it's all about in medicine weighing the risk and benefits. And the risks that may happen with getting the low-dose CT scan every year for 10 years, there is a possibility that you may develop cancer from it, but the risk is estimated to be about 1 to 3%, substantially lower than the potential advantage that it may offer in detecting the lung cancer early. So for that reason, it is not recommended for everybody. It's only for high-risk individuals who have smoking history or who are between 55 to 80 years.
So Dr. Patibandla, there was a question, is emphysema considered a type of COPD?
Yes, it is. So COPD is a broad umbrella term which stands for chronic obstructive pulmonary disease. And under COPD, we have 2 different disease types. One is emphysema, and another one is called chronic bronchitis. They basically differ in where the disease changes happen within our respiratory system. In emphysema, there is destruction more in the lung tissue. in chronic bronchitis, the changes happen more within the airways, and there is a lot of inflammation in the airways. So they differ in terms of having symptoms and how they are treated to some extent. So to answer your question, yes, emphysema is a type of COPD.
It's probably worth pointing out that if you have emphysema or COPD, you likely are or were a smoker. So you should consider lung cancer screening.
Yes, yes, very good point. I think one great point, and I think one great area Dr. Dadla has covered is like the benefits that you would see with quitting cigarettes. Oftentimes we see patients who are diagnosed to have lung cancer, who are smokers. They're disheartened with the disease diagnosis, and they're discouraged, and they feel like, what's the point now? We anyways have a cancer. What is going to make a difference if we quit smoking? So I would like to ask, Dr. Dadla or other team today, what's the impact of quitting cigarette smoking even after the diagnosis of lung cancer? Does it change the outcomes?
Yes, significantly. So we do see, anecdotally, we do see like higher chance of recurrence even after you're diagnosed with the cancer. The recurrence can occur in different areas of the lung because the entire surface area of the lungs is exposed to cigarette smoke. So the recurrence doesn't have to be at the same site. It can occur in a different site. It can be a completely different kind of cancer. It can also be a head and neck cancer or some other cancer. You still have the risk of COPD worsening, heart disease, strokes. So I would not get disheartened. I think catching lung cancer early using screening is very important. I think quitting smoking is very important, and it's never too late to quit smoking. Even after you're diagnosed with a cancer, even if it's advanced stage, it's not too late to quit smoking because it will help you to prevent future diseases and just breathe. It will help you to breathe.
I also would like to add that we know the risk of side effects are higher for active smokers. So one thing is radiation pneumonitis, which Dr. Rana talked about, the inflammation of the lungs. We know that there is a correlation of higher risk when patients are active smokers. So we know that patients who quit smoking, the side effect spectrum can be less. And so that's another rationale for quitting smoking.
Same thing is true for surgery. If you're a smoker going into surgery, your recovery is much more complicated. You're much more likely to have complications related to your lungs, such as pneumonia, which is the worst thing that can happen if you were to have surgery, and also things related to your heart, like the risk of a heart attack during surgery, shortly after surgery. All these things kind of elevated. So when I see patients who need surgery, we have a separate discussion about smoking cessation and how long you need to be without smoking to decrease the chances of complication, make your recovery as straight as possible and as fast as possible.
Fantastic. So the benefits that you would see from quitting smoking can start within days to weeks, and it can have an impact even on the surgical outcomes. So, as Dr. Dadla pointed out, we should see this as a problem. You don't need to find ways to do it by itself and by yourself. Now, I would encourage you to, talk to your healthcare team about ways to help you quit smoking. There's a lot of advancement in cigarette smoking cessation field as well over the last few years with new medicines and new modalities to help you quit cigarette smoking. So please do take help. And any other questions that you guys are thinking to answer? I'm going to look through the chat box to see if we have any more questions.
I think there was one more. Can there be internal burns from radiation, and how would those be treated in the lungs to prevent sepsis?
Dr. Dhami and Dr. Rana, I'm going to defer it to you. You guys are the magicians, as I say often, and with your flashlights technology, you guys screwed it right.
Sure, you know, I can certainly feel that. In terms of burns, I think the closest thing we can do is internal pneumonitis, which is the function of the lung. So it doesn't carry a higher infection risk because there's not any immunology compromises there. So to answer the treatment part of it, it's just the immune system is kicked into high gear because I mean that's the kind of the definition of inflammation. So we tamper it with steroids, which act upon the immune system to kind of slow down its activity and prevent further damage to the normal tissue. So there isn't a risk of sepsis related to the radiation burn that we see.
I see that there's another question about how soon would a patient expect results from SBRT. So after radiation is done, even though the beam is off, it continues to kill cancer cells for several weeks. And so we usually like to wait 2 to 3 months before we do our first scan after treatment to, kind of assess the response. And thereafter, we'll do scans to kind of assess response and, one, making sure that there's no toxicities from the radiation, but also to look for a recurrence, not just from the tumor we treat, but also to kind of have a status check on the rest of the lungs that are still potentially at risk for cancer as well.
Fantastic. Thank you both. And I think a couple other questions about the nodules. If the nodules are diagnosed accidentally or because of the symptoms. Most of the lung nodules are diagnosed incidentally, meaning we get chest scans for one reason and we are diagnosed to have lung nodules, and very less likely that they would be diagnosed due to symptoms. And that's one of the reasons why lung cancer is often diagnosed at advanced stages. So it's a sneaky disease. It doesn't cause any symptoms when it is early stage. By the time it causes symptoms, it has advanced. So most of the lung nodules are diagnosed incidentally, and that's a problem. So I think we're close to 20 minutes after the defined time frame. I appreciate all you guys sticking in, and we really appreciate your participation. One thing that I would want to kind of conclude and close the talk today is that you may have heard that lung cancer is killing many people. Lung cancer is the leading cause of death, but I think there is definitely a ray of hope, because if you look at the incidence of lung cancer, there is a decline by 2% on an average yearly over the last 2 decades. There certainly is a lot of advancements in the medical field, both in terms of the diagnostics and the treatments that is happening, that is contributing to this improved outcomes. And also at the community level, I think the smoking rates have been declining. So there has been a lot of improvement happening in the lung cancer field, and a lot of awareness occurring in regards to the lung cancer. So one thing again, before we conclude is I would like you all to take away low-dose CT scan and lung cancer screening. That's going to make a big difference if you qualify for the lung cancer screening. Any closing remarks from the team? Fantastic. Thank you so much. And I wish you all a very good night. And if you have any questions, please send them to us, and we'll be happy to answer.
Thanks. Bye.
Thank you, everyone. Have a great rest of your evening.